Good morning, everyone. Today's topic for presentation is periodontal pocket and its classification. Periodontal pocket is one of the important clinical findings of periodontal disease, and for proper understanding of periodontal pocket, one needs to have sufficient knowledge about gingiva and gingival sulcus. So, what is gingiva? Gingiva is that part of oral mucosa that covers the alveolar process of jaws and surrounds the necks of the teeth. Basically, there are three types of gingiva. There is marginal gingiva, attached gingiva, and interdental gingiva with varied surface characteristic features and functions. So, coming to gingival sulcus is a shallow V-shaped space around the tooth bounded by tooth surface on one side and the epithelium lining the marginal gingiva on the other side. And normally it measures about 2 to 3 millimeters in clinical uh, healthy human being. So when this 2 to 3 millimeters sulcus depth increases, that is called as a pocket. The points to be remembered in gingival sulcus is the boundaries, that is one side the tooth surface, one side the epithelium lining the marginal gingiva, and apex is bounded by junctional epithelium, which makes an attachment of gingiva to the tooth surface. So when this particular thing is increased, the space is increased, that is called as a periodontal pocket. So today I'll be discussing about classification of periodontal pockets. So coming to the definition of pocket, pocket is nothing but deepening of gingival sulcus. So as I've already mentioned, 2 to 3 millimeters of gingival sulcus is normal. When this particular space is increased, that is called as a periodontal pocket. That is nothing but deepening of gingival sulcus. So how does this deepening occur? Deepening of gingival sulcus can occur by coronal placement of marginal gingiva, increasing the sulcus depth, or by apical placement of junctional epithelium. So either of things can increase the sulcus depth, which is termed as a pocket. So what is the difference? When deepening of gingival sulcus occurs due to coronal migration of marginal gingiva, which is called as a gingival pocket or a pseudo pocket or a false pocket. So when deepening of gingival sulcus occurs due to apical migration or apical shift of junctional epithelium, which is considered as a true pocket. So this is a picture where you can appreciate the healthy gingival sulcus measuring about 3 millimeters on one side, and on disease side there is about 5 millimeters of periodontal pocket. So coming to classification of periodontal pockets, based on the morphology, the pockets can be classified as pseudo pockets and true pockets. So pseudo pocket is nothing but the depth deepening occurs due to marginal coronal placement of marginal gingiva, whereas true pocket which occurs due to apical shift of junctional epithelium. And sometimes you see both the pseudo pocket as well as true pocket in the same condition, that is combined type of pockets. So when pseudo pocket and true pocket occurs together, that is considered as combined pocket. So when do you see pseudo pockets? Pseudo pockets are normally seen in gingival enlargements, whereas true pockets are normally seen in periodontal disease, that is periodontitis, localized or generalized periodontitis, or even aggressive type of periodontitis. And combined pockets also can be seen when there is periodontitis associated with gingival enlargements. So based on relationship to the crestal bone, so you have classified, the pockets are classified into uh, supra-bony pockets and infra-bony pockets. So supra-bony pockets and infra-bony pockets are types of true pockets, because uh, the pocketing is taken place because of apical shift of junctional epithelium. So what do you mean by supra-bony pocket? Supra-bony pocket is defined as when the base of the pocket lies coronal to the crest of the alveolar bone, that is called as supra-bony pocket, whereas when base of the pocket lies apical to the crest of the alveolar bone, that is termed as infra-bony type of pockets. So supra-bony pockets are otherwise uh, called as supracrestal pockets or supraalveolar pockets. Infrabony pockets are intrabony or subcrestal pockets or intraalveolar pockets. So distinguishing features of suprabony pockets and infrabony pockets are base of the pocket when it lies apical to the crest of the alveolar bone, that is called as infrabony type of pocket, whereas the current base of the pocket lies coronal to the crest of the alveolar bone is suprabony pocket. Pattern of arrangement of bone destruction. Horizontal destruction is more seen in suprabony pockets, whereas vertical type of bone destruction is seen in infrabony type of pockets. And third difference what they have mentioned is periodontal ligament fibers. Arrangement of periodontal ligament fibers, that is transeptal fibers, are arranged horizontally in suprabony pockets, whereas the arrangement is oblique from cementum beneath the base of the pocket over the crest of the alveolar cementum or the adjacent tooth, which is considered as infrabony type of pockets. And coming to infrabony pockets, again are classified into bone defects: one wall defect, two wall defect, and three wall defects. One wall defect is where there is only one wall intact, whereas two wall defects, two bony walls are intact. Three walled defects are three bony walls are existent. One wall defect is also known as uniseptum. Based on number of surfaces involved, the pockets are classified into simple pockets, compound pockets, and complex type of pockets. Simple pockets are nothing but involving one tooth surface. Pocketing takes place in one tooth surface, that is called as simple pocket. Compound pockets are involving two or more tooth surfaces, and complex pockets are type of spiral pockets where the base of the pocket is not in the direct communication with the gingival margin. So spiral type of pockets are more seen in endoperio lesions. So depending on the nature of soft tissue walls, the pockets can be classified into edematous type of pockets and fibrotic pockets. Edematous type of pockets are more edematous in nature, where the fluid collection is present in the gingival surface, and you can see some sort of pitting on the surface of gingiva, whereas fiber optic pockets are fibrous in nature, but pocket depth is measured. So fibrotic pockets are more seen in gingival enlargement, whereas drug-induced gingival enlargements, whereas edematous pockets are more seen in inflammatory type of diseases. Based on disease activity, they can be classified into active and inactive pockets. So what is an active pocket and what is an inactive pocket? Active pockets are nothing but pockets when they are associated with bleeding on probing is considered to be active pockets. That means the disease is actively involved and it's progressive. Whereas inactive pockets are noticed in case of periodontal treatment when the patient completes the periodontal treatment. So to recap, so pocket is nothing but deepening of gingival sulcus, and there are various types of pockets. That is pseudo pocket, uh, true pocket, combined type of pockets. True pockets again are classified into uh, suprabony, infrabony type of pockets. Infrabony type of pockets again are classified into 1 volt, 2 volt and 3 volt defects, and based on surfaces involved, they can be classified into simple pocket, complex pockets and compound pockets, edematous pockets and fibrotic pockets, and active pockets and inactive pockets. And further to this, the clinical features will be discussed in the next lecture. Thank you.